Preeclampsia and Eclampsia. Hypertensive disorders complicate approximately 10% of pregnancies, presenting a significant challenge in obstetric care. While many cases are benign, some can lead to severe maternal and fetal morbidity and mortality. This guide focuses on two particularly concerning hypertensive disorders of pregnancy: preeclampsia and eclampsia. Definition of preeclampsia. Preeclampsia is a multi-system disorder unique to human pregnancy, typically manifesting after 20 weeks of gestation. It is characterized by new-onset hypertension, blood pressure greater than or equal to 140/90 millimeters mercury, accompanied by proteinuria greater than or equal to 300 milligrams in a 24-hour urine collection, or protein over creatinine ratio greater than or equal to 0.3. The etiology of preeclampsia remains elusive, but current evidence suggests it originates from placental dysfunction, leading to widespread maternal endothelial dysfunction and systemic inflammation. Risk factors for preeclampsia. Several factors increase a woman's susceptibility to preeclampsia. Nulliparity and a history of preeclampsia in previous pregnancies are strong predictors. Multiple gestations, chronic hypertension, and extremes of maternal age, below 20 or above 35 years, also elevate risk. Pre-existing medical conditions such as diabetes mellitus, chronic kidney disease, and autoimmune disorders further predispose women to preeclampsia. Interestingly, pregnancies resulting from in vitro fertilization demonstrate a higher incidence of preeclampsia, possibly due to underlying maternal factors or the in vitro fertilization process itself. Clinical presentation of preeclampsia. The clinical manifestations of preeclampsia are diverse and can affect multiple organ systems. The hallmark signs are hypertension and proteinuria, but patients may also present with neurological symptoms such as persistent headache and visual disturbances. Sudden weight gain and generalized edema, particularly involving the face and hands, are common. Gastrointestinal symptoms like nausea and vomiting, especially in the latter half of pregnancy, may occur. Decreased urine output and dyspnea can indicate progression to severe disease. It's crucial to note that some women with preeclampsia may be asymptomatic, underscoring the importance of regular antenatal screening. Definition and presentation of eclampsia. Eclampsia represents the most severe end of the preeclampsia spectrum, characterized by the onset of generalized tonic-clonic seizures or coma in a woman with preeclampsia. The risk of eclampsia is highest from 20 weeks of gestation up to 8 weeks postpartum. Eclamptic seizures often follow prodromal symptoms of preeclampsia but can occur without warning. These seizures vary in severity and duration and may be accompanied by altered mental status, severe headache, and visual disturbances. The occurrence of eclampsia signifies a medical emergency requiring immediate intervention to prevent maternal and fetal compromise. Management of preeclampsia and eclampsia. Despite advances in obstetric care, eclampsia still carries a perinatal mortality rate of 4 to 8%. The cornerstone of management is vigilant blood pressure control and seizure prophylaxis. Magnesium sulfate is the gold standard for seizure treatment and prevention in eclampsia. The goal of antihypertensive therapy is to lower blood pressure by 15 to 20%, aiming for a target range of 140 to 150/90 to 100 millimeters mercury. Intravenous hydralazine or labetalol are commonly used for acute blood pressure management. Immediate consultation with obstetrics and gynecology is imperative for optimal maternal and fetal outcomes, often necessitating expedited delivery in severe cases. Hellp syndrome. Hellp syndrome, an acronym for hemolysis, elevated liver enzymes, and low platelets, represents a severe variant of preeclampsia. This life-threatening condition is characterized by microangiopathic hemolytic anemia, hepatocellular damage, and thrombocytopenia. Hellp syndrome can rapidly progress to disseminated intravascular coagulation, liver failure, and maternal death if not promptly recognized and managed. Treatment typically involves intensive care management, magnesium sulfate administration, blood pressure control, and often, emergent delivery regardless of gestational age. Long-term implications. The implications of preeclampsia and eclampsia extend beyond the immediate postpartum period. Women with a history of these conditions face an increased risk of future cardiovascular diseases, including chronic hypertension, ischemic heart disease, and stroke. This underscores the importance of long-term follow-up and cardiovascular risk assessment in these patients. Healthcare providers should counsel affected women about these risks and implement appropriate screening and preventive measures to mitigate long-term cardiovascular morbidity. Take-home message. Preeclampsia and eclampsia remain significant challenges in obstetric care, demanding vigilance, prompt recognition, and decisive management. The key to improving maternal and fetal outcomes lies in early detection through regular antenatal screening, timely diagnosis when symptoms arise, and appropriate, often aggressive management strategies.
Thank you for watching. Please subscribe to our channel by clicking the subscription button. If you have any questions, feel free to leave a comment below in the comments section.